So I'm going to be talking today about some of the issues around the efficacy of adjuvant therapies for the treatment of non-small cell lung cancer, specifically pulmonary adenocarcinoma, and some of the issues that are exercising us in the pathology committee of the IASLC at the moment. So at the risk of stating the obvious, here we're talking about the patient who has a resectable primary tumor and some degree of occult disease which is not resectable. And the two stages of surgery and either adjuvant or neoadjuvant therapy are required to extinguish every one of those cells. So the prediction of benefit comes down to two things. One is the efficacy of the therapy on the malignant clones. And the second, the important one that I'm talking about today, is the judgment of whether or not those cells are actually in the patient. Now, adjuvant therapy will be valuable to any patient who recurs, so, ergo, recurrence and survival endpoints, which are almost 100% related to recurrence, are good measures of value. So what are the histopathological and tumor-intrinsic predictors of recurrence? Stage is the obvious one. There's a huge amount of information locked up in the appearance of the tumor, specifically the morphological growth pattern of the lesion. So this has become codified as grade, the three-level grade system. And then a few really important biological events. The ability of the tumor to punch through the pleura, the presence, the observed presence of vascular invasion is unsurprisingly a quite strong predictor of recurrence. And the absence of tumor infiltrating lymphocytes is emerging as another predictor of likely occurrence. So a lack of engagement of the immune system in tumor eradication. And you have other things, mutational burden and molecular signatures coming into the mix as well. So I'm not an oncologist, but sieving through the oncological guidelines reveals that this decision of giving adjuvant therapy is overwhelmingly driven still by clinical stage. And some mention is made in the published guidelines of high-risk features, but very little evidence is available to substantiate how important these are. So, there have been some very important meta-analyses which first of all confirm the value of adjuvant therapy overall, but crucially in the subgroup analyses they reveal that the value of adjuvant therapy is often restricted to high-risk morphologies, and further meta-analyses show that there's also a linkage to lymphocyte infiltration. In our own work, when we look retrospectively at a very large continuous cohort from Leicester, we find, using a propensity-matched approach, that, sure enough, there's an overall value of adjuvant therapy, but again, it's not seen in cases which lack the high-risk features, like lymphovascular invasion or high-risk growth patterns. And furthermore, and this, I appreciate this is a tiny n and we're very much sticking our necks out, but when you identify a tiny set of patients with very early stage lesions, they can do very well in receipt of adjuvant chemotherapy if they have these high-risk growth factors present. Okay, so what if we look at that very small sub-30 millimeter class of tumors and ask the question if those high-risk growth factors are still prognostic in that group? The answer is very much yes. There's been an absolute plethora of publications of cohorts, small and large, showing that so vascular invasion or pleural infiltration, showing that the predominant growth pattern, and showing that fractional growth patterns are all highly prognostic, even in this tiny, relatively small resected tumor size. And certainly if I was a patient with a 20 millimeter nodule that had any of these high-risk features, I'd be really looking for adjuvant therapy. So in summary, biologically explainable, plausible pro-metastatic features that we can see down the microscope predict both recurrence and the efficacy of adjuvant therapy. The current chemotherapy guidelines seem to me, it's perhaps easier for me to say this, being so far from the front line, but they are simplistic. The reasons for that probably mostly come down to a paucity of high-quality data, and also the way that our attention as a community is drawn towards personalized therapies. But I think it's entirely possible that by undertreating small high-grade lesions and overtreating large low-grade lesions, we may be doing a substantial number of patients a disservice. And we need more data. So what could work better? If we look at our colleagues in breast cancer, for example, there are very well-used multifactorial benefit prediction tools which are used to make sensible, data-driven choices about whether or not to administer adjuvant therapies. And there's no reason why this shouldn't happen in lung cancer. If we just think for a minute about how pathologists actually operate. So in a modern center, we might start with a digital slide tray, and we have a good look at it, and think about an awful lot of things, perceive and intellectually register dozens of factors about the case that we're looking at. But it becomes boiled down to a very few important facts. I suspect that a lot of the time there are about 10 words in the report which really make an impact on patient management. But the point is that there's an enormous amount of subtle information which is left on the table and that we can't realistically quantify or make use of. So what I'm proposing, and I'm far from the first person to propose this, is that we use AI to make more use of some of this subtle information. This is a manuscript that was accepted for publication just 10 days ago. And these are my computer science colleagues who did all the hard work. But the principle is one in which you ingest a set of images. So in this case, these are just the TCGA images for lung adenocarcinoma. The digital images are converted into small tiles. The clever thing that the AI does, this self-supervised algorithm, is for each of those hundreds of thousands of tiles, it discovers the important morphological features and projects all those tiles into a high-dimensional space. And then we can seek groups of those tiles and start to convert the original images into a vector of those groups. And we call it histomorphological phenotype learning. Now, something nasty's happened to this slide, but it predicts outcome extremely well. So now if you link morphologies to patient hazard, and use the algorithm to predict outcome in cases which it hasn't seen before, it does so extremely well with much more fidelity than current human grading. This has really mangled my slides compared to what I saw in the prep room, I'm afraid. And the clusters that it discovers are completely intelligible to a histopathologist, which is very exciting. So it's breaking down and providing a morphological language of the disease. And here we are showing how the current human assessment, so all the known big prognostic factors, age, sex, and stage, plus human grade, provide a C-index of about 0.73. A supervised AI approach gets to about 0.68 without those background factors. Our self-learning approach, without any background information, so using just the morphological appearance of the tumors, is performing just as well as the human with all the patient history. So it is definitely pulling a lot more information off the glass. So in summary, self-supervised AI is an approach that uses all the available information without prejudice, and it discovers this morphological dictionary of the disease. These recurrent morphologies are strongly linked to ground truths, so they're predictive and insightful, and we can use them as digital biomarkers. And if they can predict outcome, there's no reason why they shouldn't predict response just as well. And I feel that it's inevitable, actually, that these self-learning methods, which aren't relying upon a human gold standard for training, are going to end up dominating the AI field in this area. So I do feel that there's a real need for new large-scale randomized controlled trials to further examine the benefit of adjuvant and neoadjuvant therapies. I really welcome the neoadjuvant trials for personalized therapies in this area. But I still think there's probably a lot more value to be had from chemoradiotherapy if applied with more nuance. Any such analysis would need to be powered for those subgroup analyses, and I think it should focus on really early lesions and incorporate AI development. And I see real scope for an intelligent benefit prediction algorithm, which could be used in an MDT setting to quantify the likelihood that adjuvant therapy will help in a given case, which will be better. And those are my acknowledgements. Thank you very much.